Welcome to Roadmap to Residency. Hello everyone, I am Abhiraz. Welcome to our Club 250 Matchmaker sessions. We will be running through a few questions with you guys to help you on a journey to a 250. So, development of this patient's gynecomastia most closely resembles the pathogenesis of which of the following additional findings in this patient. So, a 45-year-old man with a history of alcohol use disorder, chronic hepatitis C, and HIV is brought to the emergency department due to altered mental status and abdominal distension. He is disoriented and unable to provide an adequate history. He is accompanied by a friend who reports that the physician has recently been drinking heavily. The patient's breath has a sweet sulfurous odor. Physical examination shows gynecomastia, pulmonary erythema, and multiple spider angiomata. The abdomen is severely distended and dilated. Periumbilical veins are noted. There is a 3 plus bilateral lower extremity edema. Genital examination shows testicular atrophy. Neurological examination shows disorientation and asterexis. Abdominal imaging reveals splenomegaly. Now, the development of this patient's gynecomastia most closely resembles the pathogenesis of which of the following additional findings in this patient: altered mental status, dilated periumbilical veins, lower extremity edema, spider angiomata, splenomegaly, sweet sulfurous breath odor. So this patient has numerous clinical findings characteristic of liver cirrhosis. In patients with cirrhosis, the gynecomastia arises from hyperestrenism, which has a number of contributing factors. Now, cirrhosis increases the adrenal production of estrogen precursors, example, androstenedione, which are subsequently aromatized to estrogens. Now, these estrogens induce the sex hormone binding globulin production, which results in the increased testosterone binding and further decrease in the free testosterone or estrogen ratio. The impaired estrogen metabolism by the liver results in estrogen accumulation. Now, besides the gynecomastia, hyperestrenism in patients with cirrhosis can promote the formation of a spider angiomata. Spider angiomata are subcutaneous vascular lesions consisting of a central arteriole surrounded by smaller vessels that blanch on compression. These are most frequently found on the trunk, face, and upper limbs. Spider angiomata are likely due to estrogen-induced arteriolar dilation and are also seen in the hyperestrogenic states. The number and size of angiomata generally correlate with the severity of the liver disease. So development of this patient's gynecomastia most closely resembles the pathogenesis of which of the following additional finding in this patient. The answer is spider angiomata because both have the estrogen pathogenesis involved in their formation. Now, let's start talking about, that in my lecture, we don't only discuss the questions, we also go in deep the theory part, all that is high end for the USMLE step 1. So now let's talk about the signs of the liver disease. So starting from head to toe, we have jaundice and scleral icterus. Due to the portal hypertension, there can be esophageal varices, splenomegaly, ascites, caput medusae, anorectal varices. Due to hyperestrogenism, there may be spider angiomata and gynecomastia. Here you can see the answer to that 2-hour question. Also, due to the hyperestrogenism, we have loss of sexual hair, loss of the pubic and axillary hair, testicular atrophy, and pulmonary erythema. The hepatic synthetic dysfunction will lead to ecchymosis and edema. Now let's talk about cirrhosis. Now cirrhosis is an irreversible diffuse fibrosis of the liver with the formation of regenerative nodules or non-neoplastic nodules without sinusoids and portal tracts. There are some other like the regenerative nodules in cirrhosis. So the hepatocyte reaction to the injury, they lack the portal tracts and sinusoids. The nodules are surrounded by the bands and fibrosis, which compress the sinusoids and central venues, leading to the intrasinusoidal hypertension caused by an increase in the hydrostatic pressure in the portal vein. And also there is the reduction in the number of functional sinusoid and the formation of micronodular cirrhosis. That is, the nodules are nearly 1 millimeter in diameter, or macronodular cirrhosis, or nodules more than 1 millimeter in diameter and varying sizes. So the cause of cirrhosis includes the alcoholic liver disease. Most common cause of cirrhosis is the alcoholic liver disease. Post-necrotic cirrhosis caused by the chronic hepatitis B or hepatitis C. The autoimmune diseases like the primary biliary cirrhosis or the autoimmune hepatitis. The metabolic diseases including hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, and galactosemia. Now, there are some of the complications that are associated with cirrhosis. So, number one is the hepatic failure. So, hepatic failure is the endpoint of progressive damage to the liver, and there are numerous coagulation defects which are caused by the inability to synthesize the coagulation factors, leading to a bleeding disorder. There is decreased synthesis of protein CNS, causing the patient to be hypercoagulable. So the cirrhotic patient are usually in the hypercoagulable state. The hypoalbuminemia from the decreased synthesis of albumin produces dependent pitting edema and ascites because of a decrease in the plasma oncotic pressure. Hepatic encephalopathy definition: accumulation of toxic products that impair the mental function in hepatic failure. Accumulation of toxic products that impair the mental function in the hepatic failure. Epidemiology, there is the reverse metabolic. It is a reverse metabolic disorder, which leads to the increase in the blood, the aromatic amino acids that are then converted into the false neurotransmitter. The increase in the serum ammonia is caused by a defective urea cycle in the liver that cannot metabolize the ammonia. So the thing is that in hepatic encephalopathy, just remember that there is accumulation of ammonia, and these ammonia are then converted into the accumulation of the amino acids, and these are then converted into the neurotransmitter, the false neurotransmitter, the GABA, and that's how the hepatic encephalopathy develops. Here you can see the alcoholic cirrhosis. You can see whenever there is cirrhosis, you have to note the nodules. So you can see how nodular the liver is. This is the alcoholic cirrhosis, and this is the macronodular cirrhosis. The nodules are more than 1 millimeter in diameter. Now, this is the micronodular cirrhosis, less than 1 meter in diameter. This is the histology of cirrhosis, where you can see the parenchyma, which consists of nodules of the liver cells surrounded by the strands of connective tissue. So these are the nodules, and these are surrounded by the connective tissue. So fibrosis plus nodules, or the regenerative nodules, is the hallmark of cirrhosis. Also, you can see in the abdominal CT in a patient with cirrhosis, the liver has a nodular contour. Okay, here you can see these are the nodular contour. This is the one nodule and second nodule. The left hepatic lobe is enlarged. This one, and there is ascites, which is the complication of portal hypertension or hyperalbuminemia. The spleen is also enlarged. Okay, so this is the spleen, which is also enlarged, which is complication of portal hypertension. CT images are very, very important for the USMLE report examination, guys. Now let's talk again some of the complications of cirrhosis. So the integumentary complications are the jaundice, spider angioma, pulmonary edema, purpura, and petechiae. The neurological complications are hepatic encephalopathy and asterixis. The gastrointestinal complication will be fetal hepaticus, anorexia, nausea, vomiting, dull abdominal pain. Hematological thrombocytopenia, anemia, coagulation disorders, and splenomegaly. Renal will be hepatorenal syndrome. Metabolic will be hyperbilirubinemia, hyponatremia. Cardiovascular will lead to cardiomyopathy and peripheral edema. The effects of portal hypertension are the esophageal and gastric varices, hematomegaly of melena. Vascular are the caput medusae, anorectal varices, ascites, spontaneous bacterial peritonitis. Reproductive are testicular atrophy, gynecomastia, and amenorrhea. And testicular atrophy, gynecomastia, spider angiomas, palmar edema. These are all due to the increase in the estrogen. Now, hepatic encephalopathy, you can see that the normal liver, the amino acids are absorbed from the intestines, are metabolized by the liver, and the potentially toxic ammonia is converted into the urea and excreted into the intestine or urine. Ammonia formed in the intestines through the action of bacteria is neutralized by the liver as well. In cirrhosis, the liver cannot degrade the ammonia entering the portal vein system from the intestine. Furthermore, the portocaval anastomosis provide venues for the ammonia-containing portal blood to bypass the liver. Thus, the systemic circulation is flooded with the extra ammonia, which is toxic and can induce hepatic encephalopathy. So the normal liver just converts the ammonia into urea, and this urea can be excreted. But in case of cirrhosis, the liver cannot do its job, and there is accumulation of ammonia inside the liver. And due to the portocaval shunt and the high blood supply in the liver, the ammonia just escapes out, and there is the blood system is full of ammonia, which can produce the hepatic encephalopathy and other features. Now, this is the typical presentation of the portal hypertension. So, when you have portal hypertension, you may have caput medusae, hemorrhoids, and esophageal varices. Now, this is the axis. The extended hand shows the characteristic flipping movement. You might have done this examination in your clinics. So now let's again do one more question. So which of the following is the primary driver of portal hypertension in this patient? A 55-year-old man with a long history of alcohol abuse presents to the emergency department with complaints of abdominal distension, generalized weakness, and recurrent episodes of hematomegaly. On examination, the patient has ascites, dilated abdominal wall veins, and splenomegaly. Lab tests reveal low serum albumin levels. Imaging studies show an enlarged spleen and findings suggestive of portal hypertension. Now, which of the following is the primary driver of portal hypertension in this patient? Hepatic artery thrombosis, hepatic vein thrombosis, extrahepatic portal vein thrombosis, sinusoidal obstruction syndrome, or alcoholic liver cirrhosis. So the primary driver of portal hypertension in this patient is alcoholic liver cirrhosis. Alcohol abuse in this patient's long history is a significant risk factor for the development of alcoholic liver cirrhosis, which is a common cause of portal hypertension. The clinical findings in this patient, including ascites, caput medusae, splenomegaly, and low serum albumin levels, are characteristic features of advanced liver disease, particularly cirrhosis. Imaging studies revealing an enlarged spleen and findings suggestive of portal hypertension in combination with the patient's presentation of hematomegaly further support the diagnosis of portal hypertension. Alcoholic liver cirrhosis. Portal hypertension is a common consequence of cirrhosis, which can be caused by chronic alcohol abuse. The development of fibrotic tissue and distortion of the liver's vascular architecture contribute to increased pressure in the portal venous system. So the hepatic artery thrombosis, the option A, is a less common cause of portal hypertension, and it typically results from the acute events affecting the hepatic artery rather than the chronic alcohol abuse. The hepatic vein thrombosis, which is the Burkitt syndrome, is characterized by the thrombosis of the hepatic veins, leading to the congestion of the liver sinusoids and ascites. While it can cause the portal hypertension, it is distinct from the alcoholic liver cirrhosis. The extrahepatic portal vein obstruction involves the obstruction of the portal vein outside the liver, typically due to thrombosis or other causes. It leads to the portal hypertension, but the patient's alcohol abuse history and presentation are more suggestive of alcoholic liver cirrhosis. The sinusoidal obstruction syndrome or the vein occlusive disease primarily involves the hepatic venules and is less common a cause of portal hypertension than alcoholic liver cirrhosis. Now let's talk in brief about the portal hypertension. So whenever the portal vein pressure is greater than 10 millimeter of mercury, then that is called as the portal hypertension. The portal vein drives the portal vein derives from the splenic vein and superior mesenteric vein, and the pathogenesis involves the prehepatic, hepatic, and posthepatic causes. The intrahepatic is the most common cause and is due to the resistance to intrahepatic blood flow due to the intrasinusoidal hypertension due to the compression of sinusoids by regenerative nodules. The anastomosis between the portal vein tributaries and the arterial system is predisposing mechanism behind the development of the portal hypertension. The complications include obviously ascites, congestive splenomegaly, and this congestive splenomegaly is caused by the increased hydrostatic pressure in the splenic vein, which is a branch of the portal vein. The congestive splenomegaly causes hypersplenism, producing various cytopenias like anemia, neutropenia, and thrombocytopenia. Also, there can be esophageal varices, hemorrhoids, periumbilical venous collaterals. Here you can see the intrahepatic, posthepatic, and prehepatic side cause of portal vein thrombosis or the portal hypertension. So the prehepatic are the portal vein thrombosis and decreased splenic flow. Intrahepatic are cirrhosis, schistosomiasis, sarcoidosis, and primary biliary cirrhosis. The posthepatic causes are vena cava obstruction, hepatic vein thrombosis, veno-occlusive disease, or heart failure. Now, these are the manifestations where it can be seen. We have already discussed capillary medusa, esophageal varices, and hemorrhoidal veins or rectal varices. Uh, let's talk about the pathogenesis of ascites. So, whenever there is the cirrhosis of liver, there is increase in the portal pressure. So, there is increased portal hypertension and peritoneal transudation. Also, there is the decreased albumin production, so which leads to the decreased oncotic pressure, and ultimately there is formation of ascites. Now, whenever this ascites is formed, there is reduced circulating plasma volume, and this stimulates the angiotensin, and also there is renal hypoperfusion. So the RAS systems gets activated and it absorbs more water. And again, this more water goes towards the peritoneum, and again the ascites is increased. So this is a vicious cycle of ascites formation. Let's talk about the clinical features of cirrhosis. We have all talked about it earlier, so no need to go through this all. But what I want you to highlight here extra is this thin hair. There is thinning of the hair, and also there is loss of the axillary and pubic hair. Everything else is from the previous slides. Now let's talk about one more question. So which of the following is most likely contributing to this patient's altered mental status? A 54-year-old man with a history of hepatitis C infection is brought to the emergency department by his wife after several episodes of vomiting bright red blood. He is admitted to the hospital and the appropriate treatment is initiated. During the morning rounds the next day, the patient is disoriented and cannot identify the mouth or his current location. Physical examination shows significant abdominal distension and gynecomastia. Repetitive flicking motion of the hands are seen, means the asterixis, when the patient is asked to out express his arms and dorsiflex his wrist. Which of the following is the most likely contributing to this patient automental status? Accumulation of blood urea nitrogen, bacterial infection of the meninges, decreased gamma aminobutyric acid receptor stimulation, increased absorption of nitrogenous substances by the gut, occlusion of the middle cerebral artery. So the patients, this patient with cirrhosis most likely developed the hepatic encephalopathy due to his recent GI bleed. Hepatic encephalopathy refers to a reversible decline in the neurological function that occurs due to the failure of the liver to metabolize waste products such as ammonia. Now, the ammonia is normally produced by the GI tract as a result of enterocytic catabolism of glutamine and colonic bacterial catabolism of dietary protein. Now, GI bleeding causes the increased nitrogen delivery to the gut in the form of hemoglobin, which is then converted into the ammonia and absorbed into the bloodstream. The ammonia then enters the liver through the portal vein and is detoxified to urea. In chronic liver failure, the hepatocyte dysfunction and the sorting of blood through portosystemic collaterals impair the liver's detoxification ability. This leads to accumulation of ammonia and other neurotoxins in the circulation, causing altered amino acid transport across the blood-brain barrier. This leads to impaired neurotransmitter metabolism and depressed cerebral glucose metabolism. These and other factors result in the increased inhibitory neurotransmission and impaired excitatory neurotransmitter release. In summarizing the hepatic encephalopathy, precipitating factors include the drugs, hypovolemia, electrolyte changes, increased nitrogen load, infection, photosystemic stunting. Clinical presentation, sleep pattern changes, altered mental status, ataxia, and asterixis. Treatment is correct the precipitating cause and decrease the blood ammonia concentration by lactulose or rifaximin. Thank you for watching.